All right. What's going on, everyone?
Yeah, Yeah.
Okay. Looks like someone did this biopsy. What'd they do it for?
Bulla.
Yeah.
Yeah. Yeah, they saw something. They saw a bulla. Okay, what kind of bulla did they see? Now that we're looking at it on the scope.
It's a sub epidermal. Looking like there's a large amount of inflammation within the actual like contents, or I mean, immediate moderate amount of inflammation in the actual contents of the bulla.
Yeah. So there's some okay, so there's an infiltrate, and but we mentioned that this was a what kind of bulla? So subepidermal, right? We agree on that?
Yes.
Okay. So in subepidermal bulla category, what kind of infiltrate are we seeing?
Looks pinkish.
Yeah, so EOs,
Yeah, EOs. How many EOs?
lots.
It's loaded with EOs. Okay. What's the first thing on your differential here? I mean, when you see a subepidermal bulla loaded with EOs,
Like,
SJF.
mm,
It's not really subepidermal though. It's more like
yeah, you're looking for necrosis.
yeah,
I'm thinking like Bullous pemphigoid, Bullous
yeah.
yeah.
arthropod.
Okay, BP, and BP is the differential for this. So as far as Bullous arthropod, what's not good for Bullous arthropod here?
You need to have like periacrine, like infiltrate, or like it may be like the EOs would be a little bit more deep down.
More so deep. Deep is the key thing. The infiltrate goes deeper, and look how clean this split is. Very clean. So you can see Bullous arthropods, but it's not it doesn't tend to have this clean of a split, and it's much like this peters out. Like there's really not a whole lot of inflammation down here. Bullous arthropods are much more exuberant than this. But yeah, BP is the like this is your classic example of BP. As opposed to this, what do we see here?
Um, there's a lot of like dermal pallor, so it was probably like almost like a wheel or something. But looks like there could be some splitting, subepidermal split, and actually the
Yeah,
infiltrates.
like look where the epidermis is. It's here, right?
Yeah.
And where's your dermis? It's here.
Yeah, so a lot.
So is this a wheel?
I guess it's more like a blister.
Yeah, there's a clear this thing came off. It's gone. All right. And what's different about this split from the previous split? Like that this was the previous. Look at
The
this.
this one looks almost like posse inflammatory, even though
Glossy
like
inflammatory.
oh no. Okay, no, yeah, you're right.
There's
It's a
inflammation
lot
everywhere.
more. Yeah, and it's like just a lot more infiltrate, and especially like deep down in the dermis too, there's more infiltrate too.
What's this? All this stuff.
Blood.
It's what?
I see like red blood cells.
Yeah, not the cells.
Oh, like
This-
fibrin?
yeah, there's these gossamer strands. So when you get a massive edema like this, the pressure just pulls the off of the dermis. And so that's a difference. And you see how this was so clean? There's a reason why. Why was this so clean? Why was this split clean?
Because you get antibodies attacking like the basement membrane connections
Yes.
of the basal layer to the basement membrane.
Yeah, it's the same exact cut. It's the same exact antibody targeting the same exact place throughout this entire bulla. And so it's going to split at the same place. Here, this is like the opposite of a clean split. This is the exact opposite. This is just ripping it. This is like the hydrostatic pressure of the edema just saying, no, you got to go. So, and you have these gossamer strands that are just hanging on for dear life. Like, no, don't let me go. So, do we think this is immunobullous?
No.
Probably not. It doesn't really have the appearance of, BP or even Pemphigus vulgaris or any of their variants. And what about the infiltrate?
It goes down deep.
Really deep,
Yeah, all the way down to fat.
all the way down to fat. Okay, so let's identify the infiltrate. What cells do we see?
Lymphocytes.
There are
Maybe some
lymphocytes.
plasma cells.
Not really seeing a whole lot of plasma cells.
Not really seeing anything else other than lymphs. Oh, some histiocytes, maybe.
Few EOs.
Yes.
How many ears are there?
It doesn't.
I mean, I feel like it's a decent amount, but it's not like the last one was like only EOs.
There's a lot of eos here. It's harder to see because of the background of the collagen is matching. It's matching the color of the granules of the eosinophil granules. But look where I circled a bunch of them.
Yeah.
Here, 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 here. See if there's a little more edematous area where it could be more easy to see. So, do you see them now?
Yeah.
Here's
So
here.
EOs with I mean a great deal with like the subepidermal split. We're thinking that this is bullous arthropod, and the fact that there's also deep infiltrate.
Yeah, it's like it's basically like it's so edematous, it basically created a split. It's a very deep infiltrate loaded with EOs. What's number one on your differential, as you said, bullous arthropod, right? So yes, this is like your exuberant bullous arthropod reaction. And that's how it's very different from bullous pemphigoid. Burn this difference into the mind. Right? This is your classic BP. This is your classic bullous arthropod. They both have EOs, not the same. All right, what do we see here?
So the split here is at the basement membrane zone. Looks like there's like acantholysis actually causing the so-called split, I guess, between the cells.
Good, so-called split. I like the way you worded that. The so-called split. And there is acantholysis. So there's something in this area, and there's something in this area.
Hmm.
Two foci of it.
Yeah. I think I see a some core
Yeah.
rods.
Yes. Okay.
Pemphigus. Or pemphigus could be one thing.
Well, acantholytic disc is pemphigus part of the acantholytic disc Pemphigus vulgaris. Let me ask that. It's Pemphigus vulgaris part of our acantholytic diskeratosis differential.
I don't think so.
Yeah, and also look how it's just look. You see how it's multifocal. Like there's just this little area of acantholytic diskeratosis here, and this little area of acantholytic diskeratosis here.
Or I feel like what is the mnemonic for the primary cancel? It's like Harley Davidson with plentiful bumper stickers or something.
You're thinking outside the box. We might need to get inside the box.
I think that might be
He's-
like an elf thing.
What are we? All right, well, let's just go through. Acantholytic dyskeratosis. What's our differential?
Well, I'm thinking of
Go
I
yeah.
didn't hear multiple people. What's our
ahead, go
differential?
ahead, Nate.
Oh, Danielle said warty dyskeratoma.
Okay, warty dyskeratoma. That's one.
There's like Haley and Darius.
Haley.
I think I'm that mnemonic, but again, when I think about it, it doesn't really. They're not as similar, but like pemphigus vulgaris and foliaceus and bullous impetigo and staph stalwart skin. But they're not like primary
Wait.
acantholysis.
But this is acantholytic dyskeratosis
Okay,
because you said there were you said there were corons.
yeah. So I guess I'm gonna take out pemphigus, take out bullous impetigo, staph stalwart skin, and then add Grover's.
Okay, Grovers. And then anything else?
Oh, I just went over one. I forget what it was though.
Darius?
No, I mean Darius definitely, yeah, but I feel like there's another one that I just
Warty
reviewed
dyskeratoma
recently.
was mentioned. We mentioned Haley. Now we mentioned Darius. Grovers is mentioned. And there are some rarer ones. Those are the main ones you have to know now. There's some others. But okay, so what of those, what do we think this is?
Doesn't look like a warty dyskeratoma.
Good. Okay.
So we can take that out. Haley is like the dilapidated brick wall, which
Mhm.
I suppose this doesn't look so much like.
And in Haley, do we see more acantholysis or more of the dyskeratosis part?
The acantholysis, I thought.
The acantholysis, yes. And that usually, and you know, what's the Elstonism for this is going to be that like there's more of they have a tendency to make the red corons, the eosinophilic corons. They don't really make blue ones, and you typically just see a bunch of corons, and you don't really see them becoming fully dead reds. We'll go through some examples, but okay, and also look at for Darius, what about Darius? Versus Grover.
If Darius you get like I mean you get clefting, but I feel like it's like more extensive.
Yeah, acantholysis. It's more broad. Look at the extent here. Like it starts here. This is all good. You're good here. Is there anything wrong with this?
Not really.
Okay, and then like here's the extent of your next lesion. That's it. Maybe you're getting into something here. You can't really tell. It's a bit ulcerated and potentially impetiginized. But what acantholytic dyskeratotic process has these little foci of acantholytic dyskeratosis?
It sounds more Grover's.
Grovers. Yes, exactly. So the point is to not confuse acantholytic dyskeratotic processes with part of your bullous differential. What about this?
This is a punch and also subepidermal. There doesn't look like there's a lot of infiltrate in the actual bulla itself. There is some like superficial you say also perivascular lymphocytic infiltrate.
Okay.
There's epidermal necrosis, like acute horn. This is no good. This is send the patient to, well, I don't know. Ring the alarm bell if this patient has SGS.
Yes, SJSTN. Those good bullas, right?
Mm-hmm.
Yeah, and you picked up on all the exactly correct points. it's pauci-inflammatory
Yeah.
relative to the extent of epidermal necrosis. Good.
Mhm.
And everyone knows not to biopsy it this way, right? Everyone knows to do a nice shave.
Yes.
Okay, we have that conversation. Good. What do we see here?
Another subepidermal blister. It almost looks pretty minimal in terms of there's not really an infiltrate.
Yeah.
So this is good for that word that was used before, pauci-inflammatory, right?
Hmm.
This is pauci-inflammatory.
Yeah, not a lot going on.
Yeah. Does anything stand out?
Uh, is there something, is there a clue about like I mean there's like a eccrine gland, but that's like kind of sparse. Can we get a clue by the minimal amount of adnexa?
I don't know if it's minimal. Like here's some
Okay.
adnexa. Here's some adnexa.
I don't know, it just looks like not a ton. I don't know. I'm thinking it just looked like just a coma blister, but I kind of have this
Oh, why?
memory.
Oh,
Okay, keep
coma
going, keep
blister,
going. Why do you
yeah.
think it's a coma blister?
It was like
Well, there's
periacrine trapping or
No, what do we see? What do we see the trapping in? Like, what do you mean trapping?
uh what is that?
Where we lose the periacrine fat? You mean?
Maybe I'm confusing two different processes.
We lose periacrine fat in morphia.
Yeah, that's what I'm thinking of. Okay, yeah.
Yeah.
And this isn't Morphia, so it's like go ahead, Nick. I think that you were gonna
Oh,
mention
I
something.
just isn't there something like because you know the coma blisters from pressure, like chronic pressure and pressure points that like the whole area of skin is like chronically ischemic, and so you might see some change reflecting that.
Do you see change reflecting that, and where do you see it?
Like necrosis of the sweat glands.
Yes. Do these like do these sweat glands look normal?
No, they look like they're almost like yeah, they don't look like they have like the round hole in them.
Kind
Or
of
they don't have
bubbly.
like yeah, bubbly.
Yeah,
Lumen, there's no lumen.
they look terrible. Like these are these are clearly not normal eccrine glands.
Hmm.
Um, and so with the pathophysiology, like why are our eccrine glands so sensitive to pressure? Pressure-induced ischemia.
Is it because they demand a lot of metabolism? Like
Yes, yes, they demand a lot of. Why do they demand so much oxygen? Why do eccrine glands demand so much oxygen?
because they have active transport, like
Active transport. Yes. Why are they involved in active transport? Why would they do such a thing?
so they can create sweat.
Yeah. And sweat is
I don't know what you're looking for, but
it's
it's
a
like against,
it's
yeah,
hypotonic, right? The
against
hypotonic
the, yeah.
fluid. So it has to, that's why it has to do active transport. It has to get those ions against the concentration gradient back into your blood in order to make a hypotonic fluid that we call sweat. And so because it's involved in so much active transport, it has that ATPase, it requires a lot of oxygen. Because the eccrine glands will require a lot of oxygen, it's one of the first things to go in pressure-induced ischemia. Cool. Good. So this is a classic. They give you the split, maybe they'll have some ulceration, and then they'll give you, they'll have some sort of clear eccrine mess up here. Be like, okay, yeah, that's a coma blister. All right. What about this?
This one's more subtle. I feel like, um, well, I can say it's like a subepidermal split, but like it's pretty subtle. Like honestly, if I got this not knowing that we're on the blistering section of the chapters, that I'd be like, maybe that's just like papillary general edema, but
Good. Don't listen. The answer's on the slide. Just because we're in a chapter doesn't mean everything's going to be a split. Remember, I gave you things that weren't splits, right? I gave you acantholytic dyskeratotic processes. So good. Papillary dermal edema. We all agree, right? We see that. Yes? Papillary dermal edema. Not a question. What else is there?
Some superficial perivascular infiltrate that again is predominantly lymphocytic. There does appear to be a few other red cells that are it's there as well in the actual infiltrate.
Eosinophilic cells.
Yeah.
Some of them may be red, some of them may be other cells. What else is there in terms of patterns?
spongiosis.
Spongiosis. Yes. Okay. What cells are in our infiltrate?
EO is lymph.
Yeah. What do we call it when we have areas where we have the eosinophils and spongiosis?
Eosinophilic spongiosis.
Eosinophilic spongiosis. Yes.
Yeah.
Okay. What does that mean?
I mean, you could rely on your mnemonic to kind of build a differential.
And so when we see eosinophilic spongiosis, what kind of emotion do we get?
Happy.
We get happy. Yes. We're happy. We're very happy.
Mm-hmm.
So what's our differential?
Herpes gestationis, arthropod assault, pemphigus,
A has
pemphigoid.
two entities, by the way, arthropod and
Oh, Nick.
Allergic.
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 Allergic. Okay, allergic. Okay.
Pemphigus, pemphigoid.
Yes. And specifically in this case, it would be if this is pemphigoid, it would be what phase of pemphigoid?
Like very early.
Yeah, it would be early before the split. So what's
Urticarial?
urticarial BP? You got to think about urticarial BP. Okay. What else?
I incontinentia pigmenti.
IP is part of the okay, IP.
E is for erythema toxicum neonatorum.
ETN.
And then D is drug eruption.
Drug. Good. Now of those, what do we think this one is?
I mean, it could be. I mean, it's not a ton of EOs, but I guess it could be like urticarial BP. It
Yes.
could be
It could be.
like it could be herpes gestationis.
Yes. Very
You know, I
simple.
suppose like yeah, you don't really get EOs in PV.
I'm sorry, what was I
Do you
didn't
get EOs in pemphigus vulgaris?
in pemphigus vulgaris? Typically,
No, right?
typically not as much, not like this,
Yeah.
typically.
I guess it could be drug.
Okay. Good. Yeah, are we thinking something like IP?
No.
Probably not. Good. Okay. And what did this one end up being? This one was herpes gestationis. Good. By the way, what test could we do if we're trying to narrow things down here?
Yeah.
A DIF. Yes. And what are we going to see on DIF?
If it's herpes gestationis, you see a linear C3 IgG in the basement membrane.
Okay, good. Yeah. And if we did say salt split skin, what will we see?
I think it's the roof.
And what's it and what pattern?
Or like U or
That
N.
correlates to N serrating.
And
Yeah.
serrating. Good.
Do you guys know the clue for IP in that situation? Like the clue finding, Ave Dino?
Oh, you mean if there's worlds of necrotic keratinocytes?
Yeah, like dyskeratotic keratinocytes with that background can get you to IP without,
Mm.
on a test.
Yeah, especially if they're so eosinophilic spongiosis with necrotic keratinocytes. You have to think about IP, especially if you see like groups of necrotic keratinocytes that are kind of like almost in a world pattern. When we get to IP, we'll go through some examples of that. But yes, that combination, start looking for thinking about IP until proven otherwise, look for kid skin findings and whatnot. But
And you could always throw in tinea with these two, it's always in there.
oh yeah.
Happy,
got that.
happy differential with the T on the end.
What
This
happened
is
here, guys?
Bullous skin.
What kind of bulla?
Oh, Bullous skin and subepidermal split.
Subepidermal. Good. Where are we, by the way?
Volar.
Volar bulla.
Yeah.
Nice.
There looks to be some festooning of the dermal papilla.
Yeah. There's festooning.
And if we zoom in on the epidermis, maybe we'll see some caterpillar bodies.
You see him?
Yeah.
Good.
Porphyria cutaneous tarda,
Yeah.
PCT.
What else are we seeing in Porphyria cutaneous tarda?
That's-
Cellular elastosis.
Solar elastosis.
Well, actually, I mean, Avi, I've heard like mixed things about that. Like, I mean, cellular elastosis makes sense because of like the chronic skin damage, but like, I'd also read that you shouldn't see it because people who have it are like being judicious about sun protection.
Yeah, there's it means you don't have to see it. So yes, it's true. If you are someone who's extremely judicious, look, any disease that makes you more sensitive to the sun is possible to give you solar elastosis. So in xeroderma pigmentosa, you can see solar elastosis, but also at the same time, it causes, they don't like it when they have the reaction, so they may be judicial in avoiding it. There was, and this is in research, this is always a question where you do a randomized controlled trial and you have some intervention, and then you look to see if there was an increase or decreased risk of some skin cancer, for example, to try and infer about your sensitivity to the sun. And the answer is, the objection is always, well, maybe it didn't work because the causal intermediary being the reaction to the sun, it made it worse, and that's why there was a decreased risk of cancer, because it made their sunburn so bad that they took extra judicious care to go inside. And I'm not sure how much I buy that, but it's something that's been brought up. So in this case, yes, I'm not surprised to see similar things being said. The reality is we have a lot of findings here, and you don't need solar elastosis. Like if we didn't have the solar elastosis here, we still have the caterpillar bodies, we still have the festooning, and what else? And we still have something else. Another finding.
Vascular infiltrate.
Well, there's an infiltrate, but there's something else going on. What's going on with around the vessels? Besides some sparse infiltrate.
Hmm. I don't think there's mucin in PCT, so I don't know.
What does the wall of these vessels look like? These look like normal vessels?
They look a little bit thickened, and so it's like fibrotic.
Yeah, they look thickened. What's up with that?
Is it have something to do with like the neuroporphyrin in the vessels? It's activated by light.
So you get this eosinophilic hyaline material that's deposited around the vessels in PCT. That's another feature that you got to look for. And let's see if I can compare that with, you can differentiate that from EPP. We'll go into that. But you see, look at this vessel. Does that have this Highland material deposited around it?
No.
Okay, it's really deep where the sun don't shine. What about these ones?
Yes.
Yes. So that's another feature. And this?
Let's see, subepidermal split. There doesn't seem to be necrosis of the epidermis, acute one. Hmm, I don't know, this kind of looks like PCT again.
Yes, it kind of looks like PCT again, but it's not PCT. So what is it?
Pseudo PCT?
Pseudoporphyria. Very good. Yes.
Pseudoporphyria.
Okay. And so what are our associations with PCT and pseudoporphyria?
You mean like histologically? How do they differ?
No. Clinically. So a way they can do this, because you are dermatology residents, they, even on your path core, they can give you something that looks just like this, and they can say, what are the clinical associations?
Oh, like
like
NSAIDs
Second
and
order
voriconazole.
questions.
Yes, NSAIDs, voriconazole.
NSAIDs, good.
doxy, hydrochlorothiazide.
What's the number one of the ones we listed?
NSAIDs.
NSAIDs, good. And what about for PCT?
That
Any
I mean, it's
medical conditions?
like like a defect thing like
You want to ask about like
metabolism.
like the U-rod and stuff like that?
So if someone, no.
Like hemochromatosis.
Yes, hemochromatosis. That's the
Hemochromatosis,
past
yeah,
medical
yeah.
history that would be associated with it. What other past
Yeah.
medical history is associated with PCT?
I don't know, can you have like some type of like mental like psych issues or whatever with that? Or the
Well, you can't say.
PCT?
We are a dermatology from all of our patients are psychiatric. But there's really two big past medical histories you have to look out for when you see this.
Hepatitis
Yeah, which one?
C, I think.
Hep C, good. Hep C and hemochromatosis. Two got to be on your mind. You're like, okay, check history, hepatitis, Hep C, hemochromatosis, and you have to know your medications for pseudoporphyria. And they can give you something, and they don't, by the way, they don't have to tell you on the exam if it's pseudoporphyria or PCT. They can just give you something that looks like that and just say, statistically speaking, what are the top associations? And they can give you 3 medications and 3 medical conditions. And the correct answer is going to be NSAIDs, Hep C, hemochromatosis.
Tricky.
I know. All right. What about this?
This looks like an intraepidermal split.
Is it a split?
Mm,
Getting there, maybe.
yeah.
But okay. What are we seeing?
Suprabasal split. Looks like it's kind of in like the granular layer, maybe like in between the granular layer and
What's going on with our granular layer?
looks
It's like
really messed up.
it's bad.
Yeah, this kind of looks normal. And this kind of looks normal. Maybe a little hyperkeratotic. What the hell happened here?
Those have a little bit of trouble differentiating.
What about this?
Sounds like you don't really see nice fine granules, so like a little bit more like punctate.
And what else? Yeah, what else do we see? We see like, what are these holes?
Is that like vacuoles?
Vacuoles. Okay, so there's vacuolation primarily of the granular layer. And what are these little condensed things? These little dots.
Are those keratohyalin granules? Well, no.
Yeah, well, some of them are a little, they're throughout over here. And some of them are going a little too down below for them to be just these normal keratohyalin granules. So what can give us vacuolation of the granular layer with these condensations? Some might say there's tonofilaments in here.
This epidermolytic hyperkeratosis.
Yes, EHK. And where do we see EHK? First of all, what's the most common way we see EHK?
Like mutations and it's like inherited or congenital.
Most congenital is not the most common way we see it, but it is a mutation. I agree. What mutation is it, by the way?
Keratin, superbasal keratins like keratin 1 and 10.
Keratin 1 and 10.
Yeah.
Yep. Keratin 1 and 10. And the most common reason we see this is it's completely incidental.
Mm.
It's just the mutation that happened incidentally, and we just see it. However, in cases where it is germline, what are we worried about?
The type of ichthyosis, I forget.
What type?
Epidermolytic
Yeah.
ichthyosis. And there's also a type of subcare that has EHK, right?
There's a pet like palmoplanta that has the HK. Yes. So if this is a baby with a colloidal body, colloidal membrane, what are we going to be worried about?
Is it just epidermolytic ichthyosis?
That was like restrictive dermopathy resulting in like respiratory distress.
What's the other name for EHK? I'll give you a hint. We're in the Bullous chapter, right? Congenital
Ichthyosiform.
Congenital bullous. Ichthy.
Bullous congenital ichthyosiform erythroderma.
Yes. Congenital bullous ichthyosiform erythroderma. Very terrible disease. But yes, that's the thing. So yes, most of the time, this is just nothing. When we see this, it's just, oh yeah, there's some incidental EHK here. The way where you really have to worry is when this is everywhere from a germline mutation. That's a problem. That's a huge problem. You got to worry about congenital bullous ichthyosiform erythroderma. What about this?
Has some acantholysis in the dermal papilla with superficial perovascular infiltrate. There's a lot of infiltrate as well with lymphocyte.
Is there acantholysis?
Oh, I guess it's just all
There's
spongiosis.
some gossamer. I see some gossamer.
Uh-huh.
And there's edema.
Yeah, so there's like a subepidermal split. I think what Scott you might be thinking of is like kind of like the dermal equivalent of like a acantholysis, although like the
Oh, yeah, yeah, yeah. Yeah, you're right,
like
Nick.
like fibroblasts don't really have connections to each other like
Yeah.
epidermal cells do. But I get what I think I get what you're saying. Like a dermal papilla, like edema.
Yeah.
Okay. So there's papillary dermal edema. We agree on that, yeah?
Mm-hmm.
Okay. Mostly it's basically superficial. There's not a lot deep going on. What's in there?
Yeah.
Newts.
Oh, newt. Yeah, no, newt. Newt.
What did we decide on?
I'm gonna say neutrophils.
Neutrophils, yes. Okay.
Or
So,
plaid. Or plaid.
Blade. What is it?
Bullous. No, not bullous. Lupus.
Itchy knees, elbows, celiac disease, well,
Uh,
not
derm-
always.
Dermatitis herpetiforma.
Dermatitis herpetiformis. That's going to be like number one on your differential when you see this, right? For the board's purposes. Newt stuffed in that papilla.
There are EOs in
Mhm.
there too, Avi. And oftentimes with DH, EOs can predominate early on, and then you get more of the neutrophilic microabscesses, just so you know, okay?
Oh yeah, there are some EOs in here. Yes. So that also can go with even more to DH. What's the rest of the play?
I think I was saying lupus. EBA is one. Dermatitis herpetiformis is the other. And I'm missing two.
So yeah, pemphigoid,
Pemphigoid, herpes gestationis.
did we get linear IgA?
Oh yeah,
Linear.
linear IgA. Yeah.
DH. Okay. How do we tell them
Wait, that's like the plaid differential?
Yeah, PLAID.
Okay. I think Elsing has one that's like Delphi with the H, but whatever.
All right. The D is dermatitis herpetiformis. So it's yeah, like pemphigoid, lupus or bullous SLE, Equisita, so EBA, IgA, like linear IgA, and then DH. What test would we want to do here? Yeah, here's our EO. Here's a good example of an EO here as well.
Yeah.
DIF. What are we gonna see on DIF? We're thinking this is
Look.
GH.
IgA in the dermal papilla.
What pattern of IgA?
Intracellular.
Intracellular.
For DH.
Yeah, it's like where's the IgA going to be and how is it going to be?
Or granular. Like there's no
Granular.
there's no linearity to it.
Yeah, it's going to be granular, right? As opposed to what's it going to be linear in?
Linear IgA
Bullous.
bullous dermatosis.
Linear IgA. Yeah.
Wait,
What if it was
sorry, go ahead.
what if it was bullous lupus? What are we going to see
Full
then?
house.
Full house, granular, IgA, IgM, fight like IgG,
Okay, so you'll see the full house.
B3.
Okay, good. So your
Just
DIF.
conceptually, why the granular versus linear in certain conditions? I have a hard time like memorizing the difference.
You mean like the pathophysiology of why IgA is granular in certain conditions versus why it's linear?
Yeah.
I don't know if we know I don't know if we fully studied the answer to that. I imagine it's the distribution of the antigen. So certain cells or certain antibodies are attracting these cells, and then they're in DH maybe there's just a cluster of those. They cluster up in this granular pattern. Look, the antibodies go where the antigens are. And in linear IgA, it's covering the basement membrane in a linear fashion, as the name implies. I'm not sure if they've studied the basic science enough to know like exactly why there's granular versus linear. So and I can tell you, you're not responsible for knowing the pathophysiology of why there's granular in one and why there's linear. Like what's the antigenic distribution and why it's granular, to explain that. I don't know. But you are required to know that DH is granular IgA and linear IgA, as the name implies, is linear IgA.
Thanks.
Very unsatisfactory answer, but look, what cell?
Newts.
Oh, so it must be DH, right?
No. I mean, that's really eosinophilic, whereas in DH that was more like
Well, the
hypochromatic.
eosinophilic, are
Yeah.
they EOs though?
No, I mean like that. You see that eosinophilic material.
Oh yeah. What do you think that? What do we think like all this eosinophilic material might be?
Like fibrin, maybe.
Some of them is the collagen, but like there's some other cells in here too.
I'm looking for like blood vessels.
You're looking for blood vessels. Good. So here are some blood vessels.
Hmm.
Something's bothering you about the blood vessels. I can tell.
Yeah.
You don't like them.
I mean like I see maybe I'm looking for karyolexis, like little,
Ah,
but
Caryorexis.
I mean I guess I can see a little bit of it.
You mean like this and this?
Yeah.
Sometimes it's easier to see when it's away from the rest of them. But like that.
This is LCV.
Yeah. So this is, I don't know if they still test this fake out, but supposedly you may get a fake out like this where they have newts stuffed in the papilla and you're gonna be like, oh my gosh, DH, right? But don't forget to check the rest. And so the reason there were newts in the papilla is because there's newts. And the reason there's newts is because there's newts and neutrophilic dust and extravasated erythrocytes because it's LCD. And this?
It's hard to see if that split is subepidermal or it's not
And why
subcon.
is it hard to see?
Hmm. The basement membrane's not super clear. One and
Yeah. What might make it not clear? I mean, the deepest out like this, if we go to the deepest level here, like is this, what is this?
deepest like that. I mean,
This the dermis, or are we still in the epi over here?
it looks like dermis, honestly.
We've
It
reached the
doesn't.
dermis. What about this? We've reached the dermis?
Yeah.
We've reached the dermis. So what's going on here?
Sup or subbasilar?
So sometimes like when we get a split, does sometimes you can see this where it's like, okay, I'm having trouble deciding if it's subepidermal or if it's intraepidermal. because the deepest areas go to the base, but
Mm-hmm.
sometimes I might see this area where it looks like there's this. What's going on?
Yeah, so that looks like you can clearly see like the basal layer of epidermis. So that looks more.
Does that have to do with like the hair follicle that's right there, or?
So it actually might, but I don't know if you know why. I don't know if we really fully understand why, but okay, what do we think is going on? Why?
I don't know. I just think that if like the hair follicles, that there's like some degree of preservation of the basilar layer for whatever reason.
Or more like, or what about regeneration?
Sure. Yeah.
So you
Magic.
can like, look, when you get a bulla, does your dermis just like, I'm chill with it, like forever?
No, yeah, it starts to heal itself.
It heals. So what's that process called?
Epithelialization.
Reepithelialization. So like, and
Where does it
reepithelialization
happen from? From the hair follicles.
from
Where?
the
Why?
hair
Because there's all this.
follicle.
Because there's all the stem cells in the hair follicle.
The stem cells are there. Yes. Okay. So you can get reepithelialization, which could confuse you. It can be like, okay, well, so it could be tricky. You can say, okay, so go by the deepest one. So you have to
Also, so reepithelialization is usually you get a squamatized basal layer. The cells aren't as basaloid. So that can be a clue to help you out.
yeah, you can see it like this. It would like, you see how this is like more eosinophilic up top here?
Yeah.
Mhm.
Even the
It's like
basal
try-
layer is going to look more like they're not going to look as cuboidal as the basal cells of a typical epidermis. So they all look more squamatized.
Oh, even the basal layer. Okay, that's helpful. So, what do we think is causing this bulla?
Lupus.
Lupus, and why lupus?
See like like a superficial and deep infiltrate, periechinine infiltrate.
Yeah, any other findings?
I can't remember lupus. I don't know. I can't remember all the features, but that's like how I think about it.
Well, what's this material, this wispy material?
This one is the one who has mucin.
Mucin. Okay, yes, there's mucin. And it's not DLE, so it's not pronounced, but is there vacuolation of the DEJ?
Yeah.
So you can get some, even in like when it's not DLE, you can get some sparse interface changes. And so, one of the things that can even be tricky here is like you can see this poor new reepithelialized epidermis is like, okay, I'm reepithelializing, but guess what? That doesn't cure the lupus, right? So you can get this process just happen anew, just to your new epithelium. But yes, this is bullous. Okay, bullous lupus. Good. This is just another example of bullous lupus. This is not a caterpillar body, by the way. So we get out of the porphyria area.
Mm.
This is a subepidermal split on volar skin. Very possy, inflammatory.
Good.
There's some infiltrate.
Yeah, it's not non-inflammatory, it's possy inflammatory.
Yeah.
So what's our differential for a possy inflammatory subepidermal bulla?
Could this be EBA?
EBA is a great, yeah, that EBA, cell port BP. What are we gonna do?
Yeah.
EIF. Okay. Well, how do we tell apart EBA from cell port BP?
The staining. So for subport BP, it would be on the it's on the roof, and then EVA it's on floor.
Oh, so salt split. Okay.
So, yeah. So
Salt
then
split.
EVA is
What's the
also
pattern? Encerated or encerated for which ones?
EBA is euterated, and then subport BP is encerated.
Cell port B. Cellport BB enter, yes, correct. And then he's usurated. Okay.
Yeah.
And you can also do Eliza. You guys remember Jonas's lecture? I'm sure you all
Absolutely.
do.
Absolutely. Join us, we adore you.
Where are we here?
Oh wow.
Can you
Uh,
zoom in on that bottom thing?
I have no idea what that is actually. It looks weird. It almost looks like it's trying to be apocrine.
Well, let's take a step back. What thing is it?
A
Before we-
gland.
Gland.
It's a gland.
It's not
Yeah.
one that we typically see on the skin.
Mhm.
I don't know. I guess maybe it's cut weird. I was thinking like something like
No, it's cut.
in the
It's cut
mouth.
just fine.
I was thinking something like it around the mouth, like a salivary gland or something.
Okay, salivary. No, you're right. Salivary gland. Yes. And then what else are we? What's missing here?
Granular layer and a sperm corneum.
And no stratum corneum, no granular layer. Any
When
hair
the
follicles?
mucosa.
I
No.
think so. Oh, okay, so mucosa, right? We're in the mouth. Why did we go in the mouth?
Because we saw something we wanted to biopsy.
Yes. Good. Generally, we do. We do those things. Okay, what are we seeing?
Looks like acantholysis.
Yes.
Um,
Acantholysis. I agree. Causing a split,
yeah.
clearly. Right? We agree it's a split, right?
Yeah.
Mm-hmm.
Okay.
Um,
Okay, so suprabasilar acantholysis.
looks like there might be some tombstoning.
Yeah.
Those epidermal.
Nice little tombstone.
Uh, is this like mucous membrane pemphigoid?
Well,
Or pemphigus. Like, because like pemphigus can't affect the mucous membranes.
pemphigus. Yes. Well, does pemphigus affect mucous membranes, guys?
Yeah.
Yes.
All the time. Yeah. Lots of times. What are you going to see on DIF?
IgG and C3 and like that intercellular spaces.
Yeah. Some people describe that as what kind of pattern?
Second wire.
Oh, pattern, yeah. What's
Uh,
this?
punch, superficial, perivascular infiltrate with oh, this is HSV? Or no.
Do you think these are viral changes?
Yeah, it looks viral.
Well, what are we looking for the viral changes of HSV?
The 3 M's.
Which are?
Margination. Like me, I feel like it's like monochromatic is another. Or maybe
Multinucleation, margination, and molding, right?
molding, yeah. I think
Are
of
any of them
lasers.
present? Do we see those here?
No.
What do we see?
Acantholysis. Did we say that already?
Lysis.
It looks more diffuse.
Okay, and there's also some, but not a lot.
Corons.
Corons.
Is this like more of a dilapidated wall?
This is the dilapidated wall. But really what I want
Interesting.
you to notice is not so much the dilapidated, so it is. So what's the diagnosis?
Haley.
Haley. Okay. But notice that there's more acantholysis than all this dyskeratosis. And also what's the color of the corons?
Red.
Red. It's a lot of red. They tend to make more red than blue corons for some reason.
Mm-hmm.
for Haley Haley.
Avi, can you just point out a Coron for me? I'm so sorry.
Yeah, look at these. This one's actually starting to try to form a grain.
Oh, okay.
When this, you imagine this just flattened out.
Yeah,
turn
yeah.
into a grain.
Got it.
And this
Intraepidermal
intraepidermal,
or like subcorneal.
subcorneal,
Yeah.
posse
Posse,
inflammatory.
posse
Except for
inflammatory.
the infiltrate here, but yes. So what's your
Lymphocyte is
differential?
lymphocytic.
This might be NEO. But yes, mostly lymphocytic. But there's definitely an infiltrate here. There's superficial perivascular, at least infiltrate, and then there's a subcorneal split. So what are we thinking?
Pemphigus foliaceus.
Pemphigus foliaceus should be the top of your differential with this pattern. Not the only
Do
thing it could be,
you
but yes.
usually not see that much material within a blister, or is that not reliable?
So sometimes, I mean, so classically, this is really a classic example of what I would take to be pemphigus foliaceus. There's really not, it's not something that you'll see with like, it's not, it hasn't been contaminated, it hasn't been impetiginized, it's posse inflammatory. There's not a whole lot going on in here. It's clearly a subcorneal split. There is also a superficial, there also is a superficial perivascular infiltrate. And then they can maybe ask you, what will you see on DIF?
Avi, you should point out like the dyskeratotic keratinocytes too, like the granular in the granular layer.
Oh,
Granular dyskeratotic keratinocytes. That's like a good clue, and oftentimes they cling to the undersurface of the roof of the blister. And
Klingons.
there's typically
And
infiltrates,
here,
right?
see the Klingons? Not the ones from Star Trek. I mean, clinging on.
Mm-hmm.
That's another clue.
So on DIF, you'll see like kind of similar like chicken wire.
Yeah, similar to like Pemphigus vulgaris, right? About this.
This is intraepidermal, again, superficial perivascular lymphocytic infiltrate with a lot of infiltrate in the actual bulla itself. A lot of eosinophilic material with some it looks like as though other EOs.
Okay, well, there is a superficial perivascular infiltrate. There's red cells here. There might be not, not seeing a lot of EOs in this case. But what are we seeing? There's the split, right?
Mm-hmm.
Where's the split?
Above the basal layer, but not subcorneal.
Yes. So we call that
Intraepidermal.
intraepidermal, right? Is a hair follicle involved?
Is Derrier?
Wait. What's the answer to my question? Is a hair follicle involved?
Vulgar.
Oh, yeah, it does look like it's involved.
You can kind of infer that, right?
Yeah.
Some hair follicle didn't just get this whole thing it's coming off. All right. Well, if the hair follicle's involved, then what is that? Does that favor Derrier or does that favor Pemphigus vulgaris?
Pemphigus vulgaris.
Okay, good. As opposed to this, Is the hair follicle involved?
No,
No.
the favored areas.
Favors Darius. In fact, you can also see. What do we see?
Corons.
Corons and
Corons.
yeah,
And notice, by the way, the color of the corond here is
more basophilic
more
it seems.
basal. Okay, very good.
Warty dyskeratoma. No,
Looks like a warty dyskeratoma. And what if I told you it was in the genital area and it was papules?
condyloma acuminata.
Well, condyloma doesn't look like quite like this. Condyloma has more of a gently papillated appearance, kind of looks like a sub without the pseudohorn cyst. But look, you said warty dyskeratoma because presumably you saw corons. You saw acantholytic
Yeah.
dyskeratosis. So what is acantholytic dyskeratosis in papular pattern of in the genital area? So there's entity called acantholytic dyskeratosis of the genital crural area, or acantholytic. The other name is, I think, like papular acantholytic dyskeratosis. It's basically just these papules of acantholytic dyskeratosis that you can see in the genitals. That's all. It's nothing more crazier than that. And this?
Again, intraepidermal, inflammatory, like a concentrated area here.
Yeah. You get a little bit over here. So similar story. There's another thing that's going on here. What's this?
Yo,
Is it?
I don't know. It's kind of small.
Kind of like the same size as these other cells, right?
Oh,
Yeah,
is that just a dyskeratotic
It's
keratinocyte?
becoming it's dead red.
Okay.
this is IP.
So that's okay. So in IP we see eosinophilic spongiosis, right?
Okay, so we would have
So
had
it's
to
not
seen
just dead reds; it's dead
eosinophil.
reds plus eosponge.
Yeah, and then also dyskeratosis, dyskeratotic keratinocytes.
Yes, but here we see. So, but what if we see instead of that intraepidermal split with dead reds? Well, what's if we just had intraepidermal split like we showed all the other times?
You know, you're thinking like pemphigus vulgaris.
And by the way, there's a hair follicle here, right? There's like this hair shaft. So we're thinking something pemphigus plus dead reds can clue us
Paraneoplastic.
into paraneoplastic pemphigus. What do we see on DIF?
Uh, isn't it like linear plus intracellular space?
So yeah, plus minus, like 50% of the time, you can actually also get a linear pattern of the C plus minus C3 IgG. So you get the chicken white appearance, but you can also sometimes see that the linear pattern as well, the basement membrane. And this?
That's a tiny little subcorneal pustule.
Good subcorneal pustules. What are we looking for when we see subcorneal pustules like this?
Mm,
Uh,
the predominant
look-
cell type, or
Like, what's a good cell to find?
like an eel.
It'd be really nice to find one, right? Why would it be so nice to find one? What would we be thinking?
erythema toxicum?
So
Unitorum?
that's part of our eosinophilic spongiosis differential, but the EOs here are down below.
Mm.
In fact, here's one. So, but what? So okay, Eo's in the infiltrate and subcorneal. Remember, the answer's on the slide. Don't think about the chapter.
Pustule.
Subcorneal
Hey.
pustule plus Eo's.
Is it AJAP?
AJAP, yeah.
Oh, Jep, yeah.
And then ending on our classic, just to show you the hair follicle involvement. All the way
PV.
down with the intraepidermal split. This is
Pemphigus vulgaris.
Pemphigus vulgaris. Good job, guys. And Shane, thank you as always for helping out.
Great job, Avi.
Great job, everyone.
Thank you, Avi.
Thank you.